Hello, all. My name is Rana Huwaidi. I am a doctoral student of audiology here at Gallaudet University, and today I will be presenting my inner ear disorder, Meniere's disease. Um, Meniere's disease was originated from the French doctor named Prosper Meniere, and in the 1860s, people had thought that the Meniere's disease symptoms came from the brain. However, Dr. Prosper Meniere was like, no, this disease originates from the inner ear. An overview of what we'll be discussing today is the pathology, the stages, the diagnosis, clinical findings of the audiogram, and treatment and management. All right, so this is Minnie. I love visual aids, so I hope this sticks in your brain. Minnie suffers from tinnitus, congestion of ear, from vertigo. So I want you to tell me what you think Minnie has and how we're going to diagnose him. By the end, you should be telling me more about his disease. First off, what is Meniere's disease? So the medical term is called endolymphatic hydrops, and it's basically a buildup in the inner ear, an increase or excess of endolymphatic pressure, which equates to the restriction of mechanics in our inner ear. Now, you're probably asking, how does that happen? Why? We don't know. Researchers do not know. However, they have come up with three theories. First one is due to the constriction of blood flow. So that basically means that the blood flow is going to decrease to the cochlear system and our vestibular system. The second one is due to respiratory illnesses, allergies, viral infections. They say that can take place. And the third one is simply because it's genetics, hereditary passed down. So that's the theories they came up with, but it's still such a complex pathology that we still do not know. So I'm gonna take your attention to this picture right over here. So it's important to note that there are two sections, the bony labyrinth, which is in blue, and the membranous labyrinth. In the membranous labyrinth, there's a fluid called the endolymph, which stimulates the receptors in our body. And when I'm speaking about this is typical in our inner ear. So the receptors then send signals to the brain about our body's position and movement. While in the cochlea, right over here, the fluid is being compressed, and in response to the sound vibrations, which then stimulate our sensory cells, and eventually they send the signals to the brain. However, in Meniere's disease, the endolymph buildup in the labyrinth interferes with the normal balance and hearing signals between the inner ear and the brain. And this is when we get our terrible big three symptoms, which I will later talk about. I did also want to go into detail and show off this beautiful picture. So we have our expanded cochlear duct. So that means that the Resonator's membrane can rupture at the apical end of the cochlea, which then equals a low frequency sensory hearing loss, which we will later talk about when we go into audiograms. So we have both these sketches from the textbook. So for this left one right over here, this sketch is showing that this pathology can expand the scaleomedia, disentending both the Meniere's membrane and the basal membrane, like we touched on last slide. So you can see both these going outwards and just getting more and more swollen. And then you have D, which is the expansion of the scaleomedia at the apical end of the cochlea. So you're really getting two views of what's happening, of the expansion and that fluid coming in. All right, if we look into this ear, we picked up the otoscope, we looked into Minnie's ear. This is what it's gonna look like unless he had a perforation or a PE tube. Even though he has Meniere's disease, this is what it's going to look like, because remember, Meniere's disease is an inner ear pathology. All right, the big three that we talked about. So there's vertigo, tinnitus, and congestion of ear. First, vertigo. The patient usually feels like they are moving around the room 360, or the room is moving around them. That's usually how it is explained by patients who have Meniere's disease. The second one is tinnitus. Low frequency hearing loss can result in low pitched roaring of tinnitus, and it's related to the pressure and effects in the apical end of the cochlea, unfortunately. And then congestion of ear. That is because there's so much endolymphatic fluid that you just feel your ear just being full and congested, and that's how it feels. All right, stages of Meniere's disease. So we have early, middle, and late. That is how I characterized everything. So early, you have your unpredictable vertigo, your hearing loss, your tinnitus. It's important to note that the hearing and full sensation, the congestion of the ear, return between your attacks that you have. For middle, vertigo attacks are less severe, hearing loss is worse, tinnitus is worse, and there are periods of remission. Whereas your late stage, there is less frequent vertigo, hearing loss, and the tinnitus become worse, unfortunately, and you're going to have issues with balance. Okay, diagnosis, how it's made. So, for your diagnosis, since Meniere's disease is such a complex pathology, it's basically a rule-out method for your diagnosis. So you have your symptoms, your hearing assessment, your balance assessment, your blood test, and your brain imaging. So for your hearing assessments, they are often repeated. Patients who have Meniere's disease, their hearing levels fluctuate. Sometimes there is a false conductive hearing test or hearing diagnosis. The audiograms are usually abnormal in Meniere's disease, and they usually are low frequency. That's the commonality. They're often unilateral, but it can get worse, moderate to severe, and can go to bilateral hearing loss. Okay, so you have your two audiological tests, your audiograms. So right over here, we have our right ear and our left ear. As you can see, it's impacted in the right ear. The audiogram shows mild and low frequency sensory hearing loss. In the early stages, you can see that divot right over there, it's going to be low in the frequency. While in the B, you could see it's more severe. That right ear is almost touching moderate to severe. It's relatively flat, but you can still see a little divot towards the low frequencies. All right, so let's move on to brain imaging. So this can entail an MRI, magnetic resonance imaging, MRA, and a CT angiography. So let's shift our attention to our left picture. So we have that normal cochlear duct right over here, and the normal pars inferior right over here. You see that white matter, very healthy, very nice. However, we switch on to the right picture. We have our dilated cochlear duct and our dilated saccule. So you see all that endolymphatic fluid right around here, and fortunately, this is one of the signs for patients who have Meniere's disease. For blood tests, Measurements range from blood sugar to cholesterol to thyroid function, testing for Lyme disease, anything that we can find, but also anything that we can rule out is very, very helpful. But it is important to know that there's no single study that diagnoses Meniere's disease. So we make sure to look at case history, physical examinations. Sometimes we even take hair and blood samples for a toxicology screening. So even though blood test is a part of the process, it's one of the least used when dealing with a patient who has Meniere's disease. So for balance systems, there are two tests. One would be the electronystagmography, and what that entails is the eye motions relate to the inner ear, measured by placing the head in various positions. The affected ear will often show a balance weakness and decreased levels of function compared to the unaffected ear. However, if it is both ears, both inner ear balance systems may show decreased activity. Balance tests are usually abnormal in Meniere's disease, with one or both ears demonstrating decreased inner ear function. For the second test, it is called the VEMP, and that stands for the vestibular evoked myopotentials. This test is fairly new. You can kind of see it's like the same idea of placing these little electrodes on here. And it's fascinating because they measure two muscles, one being the sternocleidomastoid, and the second one, the inferior rectus muscle of the eye. And it's a new way to measure the inner ear and how directly related it is to the diagnosis of Meniere's disease. All right, triggers. So, triggers can be stressful situations you're in, food sensitivities, toxic exposure to chemicals, no more than 2,300 milligrams a day for salt is what the American Heart Association guidelines recommend. Of course, salt basically means fluid retention, and we do not want that. Treatment would be some meclizine for nausea, dizziness. There's also some long-term but not permanent surgery, endolymphatic sac decompression, vestibular nerve selection. There's also steroids. For management, lifestyle adjustments, same thing, meclizine, making sure you're taking those diuretics. We do not want fluid in the ear, so anything to drain that out is amazing. Procedures. So the success of middle ear perfusion has been like outstanding. I have different pictures up here, so you see they're making a perfusion, and then they stick the PE tube in there and just put medicine through that, and these are all the steps. In conclusion, as far as management, we know that gentamicin is the best at relieving vertigo with patients with more severe Meniere's disease. However, neither medication is expected to reverse permanent hearing loss that's already occurred. Middle ear perfusion is 80 to 90% effective at relieving the symptoms of vertigo and balance disturbance, which is great. And often several doses of medications are necessary for a long-lasting outcome. That concludes everything. So, what can you tell me about Benny? What steps do you think his doctor took for him to be diagnosed for Meniere's disease? What management tips do you think his doctor gave him? Please let me know in the comments below. And last but not least is my reference slide. Feel free to visit these resources, and if you have any other questions, let me know below. Thank you and have a nice day.